sir, please welcome to our webinar. So you can take over.
Thank you, Bhargav. So, can I start the slides? Are you able to see them?
Yes, sir. We are able to see your slides, sir.
Okay. So I was asked by your team to come and present to me the carotid body tumors. So in the next couple of minutes, I'll spend time over this topic. I think anybody can stop me wherever they want or type in the questions. You all can moderate it, or towards the end, I'll be happy to answer all of that. So to begin with, I'm representing HCG. HCG is a chain of cancer centers. We have a couple of verticals, which is our fertility treatments. We have Strand, which is working on precision medicine, genomics, bioinformatics, and we have a small chain of multi-speciality hospitals also. We are currently at about 26 centers across the country. We are a publicly listed company, and we have now expanded to Africa, Vietnam, over the last few years. We have a very active academic and research wing. I serve as Associate Dean for Research and Academics. And we run fellowship courses, which is affiliated with the Royal College of Surgeons and with the Rajiv Gandhi University of Health Sciences, which is the state government-owned university. In addition, we also work some collaborations with the Nature Masterclass. And I think Bhargav will be happy to share more of these details with you all. Bhargav, I would request you to share these details because we are now trying to make this accessible to more and more students. In fact, we actually during this lockdown made this course accessible across HCG to all the students and faculty free of cost. So if anybody is interested, we'll be happy to share this course. This is a small course, which is a certified course that gives training in scientific writing and publishing, where more than 36 editors of Nature actually come and interact on an online course. It's an 11-hour course, but very, very useful, very interesting, and people can make use of this. This also gives access to a complimentary course by Nature, which is on how to be a good reviewer. So broadly talking about today's topic, I'm going to be dealing this topic with a few areas. One is largely on carotids. I'm sorry, I don't know if I've jumped through this. I skipped this, but I'm sorry that I had to do these corrections. Mainly on paragangliomas, pre-op preparations for carotid, a little bit of the operative videos dealing with intraoperative catastrophes and post-operative sequelae. So broadly, I'll touch upon these topics. Now, to actually start this discussion, paragangliomas originate from the neural crest. And if you see the cells that originate from the neural crest, there are two types, the Schwann cells and the sympatheticoblasts. The Schwann cells give rise to the Schwann cell related tumors, which are the schwannomas or the neurofibromas. And the sympatheticoblasts give rise to the paragangliomas. Now, this is a very interesting aspect that we should remember. That is the neural origin of these tumors come from the sympatheticoblasts for paragangliomas. And I'll come again a little later to what is the interesting aspect of them. The most important thing in classifying these tumors of paragangliomas is the Glenner and Grimley's classification, which is a very popular and well accepted one. Where we talk about the two types, the adrenal glands, which is the most common variety, and the extra-adrenal tumors. Now, the extra-adrenal tumors, we again broadly divide them into three types, the branchiomeric, the intravagal, and the aortosympathetic. Now, among them, the one which is of our interest is the branchiomeric, which involves the carotid body tumors or the jugulotympanic tumors. The jugulotympanic is very commonly encountered by the ENT surgeons, especially in the temporal region, and the carotid body tumors by the head and neck surgeon. So today we will be specifically focusing more on the branchiomeric variety, which deals with the carotid body tumors. Now, what's very interesting, I don't know if you all are aware, I want each one of you to sit and think, what is the role of paragangliomas in a normal human body? And ponder over this question, and maybe we'll address this towards the end. But I want all of you all to think about what is the role of paragangliomas, which are present all through the body. What is their role in an adult human being? And what is it that they play as a role to assist in which parts of the body? Now, with that, the incidence of paragangliomas primarily comes from the adrenal gland, which comprises of more than 90% of the tumors. The extra-adrenal gland tumors comprises of 10%. This is very important to know, that most amount of paragangliomas will be dealt by GI surgeons or by the specialist, and the 10% of them, again, if you see the extra-adrenal ones, they will be dealt. 85% of them arise in the abdomen, 12% of them in the thorax, and only 3% will come from the head and neck region. So head and neck surgeons deal with a very small variety of percentage of paragangliomas, majority of them being the pheochromocytomas, and the other extra-adrenal sites, abdomen being a very common area. So again, bringing the question to you all on what is the role of paragangliomas in the normal human body. So if you see, coming specific to head and neck paragangliomas, we have the carotid body tumor as the most common variety, followed by jugulotympanic, vagal, laryngeal paragangliomas, tracheal paragangliomas, paragangliomas arising from the nasal cavity or from the orbit. These are known sites that have been described and documented earlier. Now, often point that comes to our thinking is, what is the difference between a carotid sinus and a carotid body? Now, this is very, very essential to understand that the carotid body, as I'm pointing it out here in this diagram, is a part of the paraganglion cells, which are present at the bifurcation of the common carotid artery, where it bifurcates into the internal and external. Whereas the carotid sinus is present as a swelling just at the root of the internal carotid artery beginning. Now, in terms of functionality, they are different, because carotid body is a chemoreceptor and the carotid sinus is a baroreceptor. So you need to remember this, that one handles the blood pressure, which is the carotid sinus. It handles the blood pressure. So any single fluctuations and changes there, it directly reaches out to the medulla and sends the messaging through the Herring's nerve itself, and changes or manipulates the body's blood pressures. Whereas the carotid body is a chemoreceptor, not a baroreceptor, and its functionality is described in this particular diagram. It basically maintains three important components: the pH, the oxygen, and the carbon dioxide. And that's why these two have to be distinctly understood. And one needs to remember that both of them are very closely interconnected. So when you are dealing with the carotid body tumor surgeries, there is all possibility that you may disturb the carotid sinus also. A very important thing over the recent past that has come into imaging advancements is the gallium-68 Dotanox scan. Now, I've just put a couple of images here from my patient. It's very important to understand that this particular advancement in the gallium-68 Dotanox scan is basically to detect multi-centric paragangliomas. Then you may ask me, why is it necessary for us to do a gallium Dotanox scan? Now, the importance of this in today's era, which we need to highlight, is that if you see in head and neck paragangliomas, 10 to 20% of the paragangliomas can be multicentric. I earlier in the previous slide showed you in this. You may have a carotid body, a jugulotympanic, vagal, laryngeal, tracheal, nasal, or an orbital paraganglioma. Over and above that, if you see this particular slide, you may also have adrenal paragangliomas, you may have thoracic paragangliomas, abdominal paragangliomas coexisting. Now, this can be known in about 10 to 20% of them, that it can vary. You also need to understand that in this particular group, that there are some studies and literatures that are published that if it is a sporadic one, they have shown instances as high as 40% of multicentricity, to if it is familial, as high as 80% of multicentricity. So this is very, very crucial for you to understand that if you look at over the last 30 years of literature, they have given a wide range, but on average, you may safely assume that 10 to 20% of the paragangliomas can be multicentric. Now, by definition, these are rare tumors and represent 65% of the paragangliomas. In the previous slide, I told you of the head and neck paragangliomas. most of the paragangliomas arise from the carotid body tumors, and then the second most common is the jugulotympanic. So more than 2/3 of the head and neck paragangliomas are represented by the carotid body tumor. And as I told you earlier, these tumors develop within the adventitia of the medial aspect of the carotid bifurcation. Now, etiopathology. I again earlier alluded to familial versus sporadic. Now these three particular etiologies are well described. One is the familial variety, which comprises of 10 to 15% of the group of carotid body tumors, which have been mainly implicated to 4 genes of succinate dehydrogenase. 85% of them are sporadic, and a small percentage of them are known to be hyperplastic, which can be related to high altitude, COPD, cyanotic disease, or OSA. 5% of the carotid body tumors can be bilateral, and up to 5 to 10% of them can be malignant. Now, with this entire thing, I'm again reiterating that sporadic tumors, generally the instance of multicentricity is 10 to 20%. And in familial, the incidence goes much higher, to as high as 80% of them have shown to be multicentric in some published literature. Now, this is very relevant from a workup point of view, because today we are in an era of a lot of informed decisions. A lot of patients may ask you this particular question to check on whether there is any investigation to find out if there are any other tumors elsewhere in the body. I have dealt with a few of them who later on came to know that there was a second tumor years later, some of them decades later. So it is worthwhile to counsel these patients well in advance and explain to them that there is a modality available. It is not mandatory. However, this information and sharing this information about the Dotanox can may be worthwhile from a discussion point of view to give them the options. Now, this is a very interesting topic about malignancies in paragangliomas. If you see my earlier slide, I said here that 5 to 10% of the tumors of the paragangliomas can be malignant in nature. Now, malignancy has been reported in several locations, but there is no established cellular criteria, which means you cannot tell your pathologist to tell you whether this is malignant or not. There are no cellular criteria. So stop pushing your pathologist to give you this diagnosis or blaming them for this, because this is beyond their purview. Now then, how do you determine whether this particular tumor, is it a metastasis or is it a multicentric tumor? Now, I earlier again alluded to this point that 10 to 20% of the paragangliomas of the head and neck region can be multicentric. So then how do you ascertain this topic and say which is metastatic, which is multicentric? So I'm going to take you back to the previous slide that I spoke. If you see head and neck paragangliomas, the carotid body tumors, the jugulotympanic, the vagal, the larynx, trachea, nasal, and orbital are well-known areas where they have known to be multicentric. If the tumor is seen in any other region, that means if you see the diagnosis of a paraganglioma, then any of these 6 regions, 7 regions in the head and neck area, you can safely call them as metastatic, which means, let's say, for example, you have found them in the lymph nodes. Now, generally, paragangliomas don't come in the lymph nodes, so you can safely put them as not multicentric but metastatic. However, if you see a paraganglioma that is also in addition to the carotid body tumor present in the nasal cavity, you cannot call it metastatic, but you should call it as a multicentric paraganglioma. This is another very interesting aspect about paragangliomas. All paragangliomas have neurosecretory granules, but only 1 to 3% of them are functional. So please remember this, that you need not panic about a secretory paraganglioma, because 97% to 99% of these tumors will not be secretors. However, what is important for you to know is the tyrosine kinase pathway, the tyrosine pathway. Now, the tyrosine gets converted to L-DOPA, which further gets converted to dopamine, norepinephrine, and norepinephrine to epinephrine. Now, at this crucial step, there is an enzyme required called phenylethanolamine N-methyltransferase. This particular enzyme is typically deficient in paragangliomas. So what happens in these kind of settings is that if it is a secretory carotid body tumor, then he will have high levels of norepinephrine in the serum blood. Now, typically when you do blood test to check whether the patient is a secretor or not, you do a urinary VMA, or you do serum metanephrines, or you can do serum catecholamines. Now, if you do serum catecholamines and if you find that the blood levels of norepinephrine are very high, but that of epinephrine are normal, then you can safely conclude that this is a carotid body tumor, which is a secretor. However, if you see that both of them are very high, that is epinephrine and norepinephrine, you can then also conclude that there is another tumor, possibly a pheochromocytoma, which is the source of this particular secretion. Now, why I am explaining this again is it is important to understand that head and neck paragangliomas don't express this enzyme. So the characteristics of a tumor. Now, most often amount of the time, you see patients present to you in an asymptomatic palpable neck mask in the anterior neck of the triangle. The typical doubling time of a carotid body tumor is 7 years. So if a patient asks you that, can I observe this particular tumor and how fast will it grow? A simple answer to give to the patient is that the tumor will double its time over 7 years. So like the way we talk about a 5-year survival, here you can roughly talk about a 5-year survival in them where the tumor will go double in size. And this is very important, especially when you're dealing with an elderly population. If you get somebody who is in the 60s, 70s, 80s, this kind of a counseling becomes very relevant, because for all you know that most of these patients will remain asymptomatic with a palpable neck mask unless there are some kind of multiple cranial nerve palsies or other symptoms that are the presenting features in them. And the median growth rate in these patients is almost about 1 millimeter per year. And this is a well-known entity. Now, the popular sign that is described here is the Fontaine sign when you see cranial nerve palsy, which means the patient, in addition to this, in about 10% of the time, can present with pain, hoarseness, dysphagia, Horner syndrome, or a shoulders droop. So this you have to keep in mind that Fontaine sign may be present in about 10% of the people. The blood supply and the nerve supply to the carotid body tumor. Now, the gland we all know is a very highly vascular gland and receives its blood supply primarily from the external carotid artery from the ascending pharyngeal branch. The external carotid artery has 8 branches, and the ascending pharyngeal branch supplies the carotid body tumor. It is also innervated by the Herring's nerve, which originates from the glossopharyngeal about 1.5 centimeters distal to the foramen. Now, like I earlier said, majority of them come with an asymptomatic swelling. And typically you may not find any other family history, but it's important to ascertain whether there is any family history and whether there is any neurological deficits. Now, I'm just giving you a very simple example of a patient who presented to us with 3 into 3 centimeters tumors over the bifurcation, pulsatile swelling which was transmitted, restricted mobility in the vertical plane because it is along the carotid artery. So it will be mobile in the horizontal plane but restricted in the vertical plane. And the bilateral cords will be mobile in most amount, that is more than 90% of the people. And the BP or pulse will be normal. But all of these become important points for you to ascertain and examine, which means you examine the neck mass, its size, its consistency, check for pulsatile swelling, whether it is transmitted or whether it is expansile. If it is expansile, it could be presenting an aneurysm there. The mobility of the swelling should be restricted both in the vertical plane especially, and if it is restricted in both the planes, you may be dealing with a lymph node there which is metastatic. Cords usually are mobile, and if it is not, there are 2 possibilities. One is, like I earlier told you, the Fontaine sign, and the other one is possibly another laryngeal paraganglioma also contributing to it, or other etiology. And blood pressures will be higher, especially in persons who are going to be having secretory tumors. Another very important pathognomonic sign for these patients, pathognomonic sign for the radiological findings, is the presence of iso to hypointense compared to a muscle. So if you see this area and if you see the surrounding muscles, it will be iso or hypointense in these regions, in this area. And it may also exhibit a salt and pepper appearance. Now, a salt and pepper appearance typically comes because of combination of punctate regions of hemorrhages and flow voids. So when you get a slow flow in that region, you get a salt appearance. And when you get a flow void, you get a pepper appearance. So the white and the black spots intermingle together, as you're seeing over here in these areas, can be seen both in T1 and T2 to a great extent. And in T1, they show very intense enhancement. So there are two images here. One is post contrast, you're seeing the enhancement here. And the pre-contrast, you are seeing the iso to hypointense compared to a muscle that you are able to see in this area. And the salt pepper appearance. The T2 part of the imaging for MRI shows a hyperintense image compared to the muscle. As you can see in the surrounding region, the sternocleidomastoid could be an easy comparative point. If you can see here, compare this image with the sternocleidomastoid. So you see that the sternocleidomastoid versus this, the intensity is almost very similar to slight hypointense patches which are present in this region and the intensity here. Now, similarly, when you're looking at this, you can see various salt and pepper appearances that can still be appreciated in these particular areas, which can be, again, like I'm reiterating, it can be because of hemorrhages, or it can be because of flow voids, and it can be because of the slow flow systems. So coming now to a very important radiological sign. The Lyra's sign is a very popularly described radiology sign by our radiologists, where you see the typical splaying of the carotid artery like this. Now coming to understanding what should be the pre-op assessment for the carotid. Now I would like to at this juncture tell you all that while I'm specifically targeting the carotid body tumors, remember this particular assessment is a very generic one for any carotid artery, especially when you're dealing with two important scenarios. One is the N3 nodes, and the other one is with regarding to salvage surgeries. These particular areas, when you're dealing with a large node, it is worthwhile keeping these key important aspects in mind. Now, there are four things that I would like to communicate here. First important thing, which is very, very important, is the assessment of the carotids is very, very relevant and important because it is a part of what we call risk communication, which means now one of the areas where you need to sit down and counsel your patients statistically and realistically is in the area when you deal with a carotid body tumor or with a large advanced tumor that deals with the stuck, which is adherent to the carotids. So risk communication is a very, very important aspect, especially if you're not doing a large amount of these surgeries, or if you're not in a center that is not dealing with this, all the more you need to be giving a lot of emphasis on risk communication. Second is choosing the right surgical candidate, intraoperative planning, and post-operative algorithms. I will be speaking on each one of these in the next coming minutes. Now, when you look at the most important understanding, and this is a very good study that was published in Head and Neck Surgery in 1982, and a lot of these lessons were learned decades earlier by our teachers and our mentors. Now, the title of this study was Management of Inadvertent Injury to the Carotid Surgery during Head and Neck Surgery. So if you see in this, the incidence of cerebral complications in elective versus non-elective ligation of internal carotid artery. The study showed two important headings. Under the elective setting, they found about 17%, and in non-elective settings, they found that the complications of cerebral complications was as high as 88%. Now, what is the message that you derive out of this paper? It is simple, that whenever you are electively doing carotid artery ligation of the internal carotid, there are a lot of important lessons. You see that the incidence of cerebral complications are very low. Now, why could that be the reason? What is the reason for that? Especially because a lot of the time when you plan an elective case, you have a selection which is biased, because you know in these cases you may not succeed, and hence you may not take up these cases at all. Whereas in non-elective cases, you may not have had the option, and hence you have to take a decision. So as a general rule, remember that if there was no bias and if you were to try ICA ligation in almost all of the patients that you non-selectively would do, you would somewhere reach complications as high as 90%. And that is why it is very important for you to know as head and neck surgeons that Injuring the carotid artery has extremely high complication rates, as high as to the tune of 90%, sometimes as good as 100%. So it is important for us to assess pre-operatively and look for one important thing, that is collateral cerebral circulation. Now, why is this important? I think I'm just going to go into this slide on why is this important, and again come back to this. Now, this is the entire premise that lies between this slide of mine, which is the complication versus preventing the complication. So if you were to injure the carotid, or if you were to sacrifice the carotid, you need to understand that in such an instance, if you have to reduce the complication rate, it will only be possible if the circle of Willis is patent. Only when the circle of Willis is patent can you actually prevent complications, the cerebral complications and others. So coming back now, that is why it is very, very important for you to assess for collateral cerebral circulation, whether it is active or not, between the internal carotid artery systems, the anterior cerebral arteries and the middle cerebral arteries. This particular zone and the posterior cerebral arteries, this particular zone, which we call the circle of Willis, is very, very crucial for you to prevent cerebral complications. I'm reiterating that, and hence it is utmost crucial for you to deal with assessment preoperatively in carotid body tumors or any other surgery that you feel the carotid is at risk. So there are a list and batteries of tests that you should know are available today in the world and be practiced easily, starting with the MARTAS test, the Xenon CT, the balloon occlusion study, the digital subtraction angiography, the CT and MR angiography, transcranial color-coded duplex sonographies, catheter angiographies, EEG monitorings, and stump pressure. Now, broadly, when you look at this, I don't want you to get confused with these batteries of tests. But what you need to know is the surgeon will need to deal with, number one, is interventional radiologist, cardiovascular teams, or they would have had to deal with radiologists. These are the three categories of friends you will need to do when you are going to be dealing with the collateral cerebral circulation. But the most simple of this was described by Martas way back in the 19th century. Now, Martas is considered one of the forefathers of vascular surgery, and he described a very simple technique which he first experimented in dogs. He showed that just by pressing either the carotid or the femoral for a few minutes, you can clinically predict neurological deficits. I think that's as simple as that. So a lot of advancements has been done on Martas test way back from when he described it in the 19th century. Rudolf Martas described this particular test in the 19th century, and from there a lot of advancements have been done. But simply what you need to know is, if no sophisticated tests were available, Martas in the 19th century described a simple test which gives you a fair assessment. It's not a very sensitive test, but a fair assessment on predicting neurological deficits. So what are these other tests? Xenon CTs, we don't have them currently being done in majority of the centers across India. Balloon occlusion study can be done with the interventional radiology team. In fact, what is very popular nowadays is the balloon Martas test. So they do the balloon occlusion study is also popularly extended to a balloon Martas test, where they actually check keeping the inflated balloon at the site to check for collateral circulation and simultaneous EEG monitoring or clinical deterioration of symptoms. MR and CT angiographies can be done, and stump pressure. So I'm going to talk a little bit about each of these later. Now, you may ask me, what is the incidence of stroke in these cases? Now, incidence of stroke by ligation of internal carotid artery can be as high as 66%. So in general, cerebral complications can be as high as 90%, and 66% of them could be because of ligation of the internal, could lead to strokes. So majority of the complications, up to 66% to 70%, can be strokes related when you ligate the internal carotid artery. And I'm saying this because, again, you need to re-emphasize this in the counseling for your patients. Another very important thing that I'm showing in this slide is that even after passing the balloon occlusion test, 25% of the patients later on had a complication related to this. They had a stroke which happened later, some of them years later. So it is very, very important for you to understand and also counsel the patient that if you first counsel them and say, look, there is a high chance of complication in this particular case that you may have to ligate the internal carotid artery, which case there is a 90% chance of a cerebral complication, a 66 to 70% chance, which means 2/3 of them may have a stroke if I have to ligate the artery. And in order to prepare for this better, I will do a balloon occlusion test. However, just by passing a balloon occlusion test doesn't give you guarantee to say that nothing will happen. Despite having a balloon occlusion test negative, 1 in 4 will also have a stroke. And this is very important to communicate to your patients that none of these tests are foolproof, but these are all what I would say is putting your best foot forward, using a minimalistic approach to prepare for a complicated case. And I again told you all of this revolves around the principles of the circle of Willis. Another very important test practiced by neurosurgeons and cardiovascular surgeons is to check the cerebral blood flow, that if it's greater than 30 cc per 100 grams per minute, then the chances of stroke in these particular instances and cerebral complications is very less, which means, again, going back to the slide, that your circle of Willis is active. And again, I want to reiterate, all of these particular tests will finally come down to this one single principle of the COW and checking whether the cow is active or not. Now, I'm just sharing with you an angiogram that was showing the left common carotid artery, showing the tumor blush. If you see, the carotid body tumor is quite vascular, as seen in this thing, that the angiography is showing that there is an intense enhancement in the tumor. And post the embolizations, this particular patient had a good embolization of that area. Now, I just want to address one simple question in this particular slide. Is embolization necessary for carotid body tumors? Well, the simple answer is no, it is not mandatory. You may ask me, why is it not mandatory? The simple reason being, I often say this, that a carotid body tumor is a very vascular tumor, but unlike a nasopharyngeal angiofibroma, remember the tumor is not the problem of the bleed here. Like nasopharyngeal angiofibromas, it is the tumor that bleeds. And hence, because the tumor bleeds, you embolize the tumor. Whereas in a case of a paragangliomas of the carotid body tumor origin, the biggest worry and fear you have is the carotid body, the carotid artery itself bleeding. So a lot of us do surgeries of the carotid body tumor without embolizing it. Number one, you may want to embolize it if it is a very large tumor and extremely vascular with a lot of surface vascularity, in which case it reduces your operative nuisance time, because otherwise you'll need to keep coagulating these blood vessels. And thirdly, in these instances, it's important for you to know that that there is a chance of a stroke which can happen in about 5% or less people because of embolization. So embolization has two problems with it. One is added cost. It may cost about 1.5 to 2 lakhs extra. If it's an institution, again, a minimalistic cost of, I think, about 1 lakh at least that you may have to incur on catheters and other consumables. The other important aspect with regarding to the embolization is neurovascular complications that have been associated with embolization. So these two things have to be kept in mind, that it is not mandatory. Now, coming to this aspect, so I hope you all have understood whether embolization is necessary or not, and the answer is no, it's not mandatory. However, if you feel, and if the patient also feels that he may want to consider that, you can advise them so. Now, I'm coming to the other important aspect, which is the Shamblin's classification. So Shamblin's classification is a very, very popular and a well-recognized classification that was published in the American Journal of Surgery in the early 70s. And this particular landmark contribution by Dr. Shamblin was based on three important findings. Now, every time that you deal with the Shamblin's tumor, you deal with the carotid body tumor, you often popularly use the Shamblin's classification. This classification was based on three important things: gross tumor vessel relationship, intraoperative finding, and post-operative specimen examination. Now, what Dr. Shamblin described was, he said group 1 tumors have a minimal vessel attachment and they are easily resectable. Group 2 are partially surrounding the vessel. They are more adherent to the adventitia. They will have a difficult dissection and they are amenable to careful resection, which means you need not sacrifice the carotid. And the group 3 are intimately adherent to the vessels and impossible for surgical dissection in this setting. So you have these three groups of tumor that are well acknowledged by the Shamblin's classification. So we went ahead and actually published this data with the in Tata Memorial on why there was a need for another classification. This particular publication was contributed by Dr. Sukita Arya and me to the American Journal of Neuroradiology with assistance from our entire head and neck team here. This title was Carotid Body Tumors, the Objective Criteria to Predict Shamblin's Group on MR Imaging. Now, this article has been multiple times featured, and it's been featured even in the articles of the decade in the AJNAV that came up recently. We did a very simple analysis and we actually came up with one critique. We found that when you talk about this Shamblin's classification tumor, you need to know that this is a post-operative classification, which means you have divided the patient into group 1, group 2, or group 3. Now, at the end of it, imagine this, that you have dealt with the group 3 tumor. So you have actually dissected the carotid and ended up sacrificing it. You come out to the family and you tell them, look, this was a group 3 tumor and you have ended up sacrificing the tumor. In which case, could you have done anything better at this point in time? Nothing much. So it's a post-operative classification. Now, we generally had one simple suggestion, that was, whenever we do a classification, it should be able to direct therapeutics and improve quality of life or decision making in a patient. So we actually proposed a simple classification, which was a type 1, type 2, and type 3 tumors based on the degree of contact with the internal carotid artery. Which means that if the degree of contact with the internal carotid artery was less than 180 degrees, like you're seeing here, it is a type 1 tumor. And if the degree of contact was 180 to 270, then it is a type 2 tumor. And if it is more than 270, it is a type 3 tumor. Now, what is the advantage of classifying it like this? The advantage is, now I'm showing you type 1, 2, and 3 through the 3 respective images. So when you say type 1, now in typically type 1 tumors, it means, I'm just going to go into the next one here. In type 1 tumors, what it means is that this, like what Shamblin said here, are minimally attached to the vessel, easily resectable, and hence you may not require a cardiovascular surgeon. So for example, I was invited by Dr. Mohan Appaji once, few years back, to Madikeri, to Coorg, to operate in his hospital and demonstrate a carotid body tumor. The lady was very poor. She was not able to travel. And in that context, he asked me whether we can do the surgery there. We studied the MRI and we found that the degree of engagement of the particular tumor was hardly at about 140 degrees. Now at that juncture, we said to him that maybe we can actually do this particular surgery in his hospital in Coorg rather than the patient traveling here. So the advantage is, if it is a group 1 tumor, and the degree of engagement is less than 180 degrees, it will be easily dissected out by the head and neck surgeon alone without having a cardiothoracic or a cardiovascular surgeon next to him. If it is a type 2, it is very important for you to keep a cardiovascular surgeon on standby. Now in India, if you know, it is very, very difficult to get a cardiovascular surgeon, even if he's in the neighboring OT. You will need a prior slot to be blocked by them. You know, I have a good couple of friends, cardiothoracic, and I keep telling them this, that even next door, if they are available, their availability sometimes seems to be very difficult because they themselves are caught up in very complicated cases for very long hours. So it is unlikely for you to suddenly ask him to stop the surgery and come into your work. So it's very, very crucial for you to know if it is a type 2 tumor, which means if it is 180 degrees to 270 degree encasement, this particular patient, you need to request and block the time of your cardiovascular surgeon and keep him in the lounge in your OT, free, during the time of your surgery. The third, which is the type 3 tumor, which is complete engagement of the carotid body from 270 to 360 degrees. In such an instance, we request that you be sitting in the lounge and allow the cardiovascular surgeon to start the surgery with the shunt bypass, and then after that resect the tumor. Now, this was a simple classification we made to show that these three varieties of tumors pre-operatively itself can be categorized into easily resectable with assistance from a cardiovascular surgeon, and taking the cardiovascular surgeon as the lead and you being an adjunct to the surgery. So this is what we described to this paper. The full text of this paper is available. I'll be happy to share more on this. The other thing that we actually described was this paper, which we called the in-text technique by us in the Indian Journal of Surgical Oncology. This particular technique called the in-text technique means internal to external carotid approach. Now I can explain to you why we actually published this paper and what was its relevance. Like I told you, the external carotid artery has 8 branches in the neck. Now, typically, if you talk to cardiovascular surgeons, they often describe this particular dissection technique as external to internal, which means one of the surgeries that I was operating, our vascular surgeon commented to us that you're going the wrong way, because we were actually operating on the internal to external carotid. So we just had a very logical discussion on this, and this ended up in this paper called the in-text technique, where we said it is always useful and advisable to dissect the internal carotid artery first and then the external. And I gave a few reasons why. Number one, if you see this, now before I explain that, I wanted to explain what the vascular surgeon had in mind. He said the carotid body tumor is supplied by the ascending pharyngeal artery, which is a branch of external carotid artery. Hence, it is better for you to ligate that vessel first, control the bleeding, and then go and dissect the tumor. And with that rationale, he told me that you should do the external carotid artery first and then the internal carotid artery. So I had argued at that point in time with certain rationales that I believe will be more relevant for my side, which is the internal carotid artery should be dissected first. The reason being, the internal carotid artery, number one, is more important than the external carotid. When you start the surgery, you are more fresh. Number three, the internal carotid artery comes first and then the external carotid artery. Hence, and number four, the cardiovascular surgeon, if required, it is better to bring him in earlier than later. So with all these 4 reasons, I actually described this paper saying it is worthwhile to start the dissection with the internal carotid artery when you are fresh, when your cardiovascular surgeon need not be made to wait for too long until you spend hours together. And lastly, if you touch the external carotid artery with those multiple 8 branches, you are going to end up having multiple bleeding points at multiple spots, and you will waste a lot of time and energy getting frustrated with bleeding. Whereas if you start dissecting the internal carotid artery, thanks to this particular branch having no branches in the neck, you will comfortably run on it like a highway and dissect this thing. As you are seeing in this diagram, you will be able to nicely tease it out of the internal carotid artery, dissect the complete thing. Even if there is encasement of the external carotid artery in much more extensive ways, you can sacrifice the external carotid artery without any major loss. So we actually were able to reduce the timing of the carotid body tumors in those last 10 cases very, very extensively, just by following the in-text technique. And I believe this is a worthwhile technique for you all to follow. So this is a very short clip that I'm showing of dissecting of a large carotid body tumor. Now this particular patient, if you see it, I'm sorry, this particular video is in a fast forward mode. You know, Bhargav, I think Akshay has a very nice video further than this. You can ask them to have Akshay show one of those nice videos also. I think his video is better than this. But generally, if you see this, we are showing the way the dissection begins here. Now, the common carotid artery, I often start the dissection for the carotid body tumor here with the common carotid artery. Now, this is a very simple clue for you to get the plane. So if you want to get the plane, remember to start here. This is a very, very interesting, simple tip for you, that you will get the plane very easy when you start dissecting the junction of the common carotid artery. And this is where, if you see, a lot of the time in the vascularity, if you see these multiple small vessels that you're seeing on the carotid body tumor, now these are the kind of cases wherein you may want to actually use the embolization technique in order to embolize the tumor. As you're seeing over here, you may encounter multiple spots of bleeding at various spots in order to control the thing, but these are not, these are from the surface vessels, especially because there are very large vessels. You can see over here the hypoglossal nerve overarching over the tumor, and you're able to dissect this. You're able to retract and dissect the hypoglossal nerve, form it. Now, again, like I told you, whenever you are dissecting it, now here we are retracting the carotid artery very meticulously from this region. And this was a very large tumor. And you were able to see that each plane of dissection in this kind of instances is very, very crucial. Now, most of this again unedited, but in a fast forward mode to show you how it is important to deal with these regions. And a lot of the time, if you see some aspects of this, we are dealing with even with the unipolar carotid. Now, this is the main common carotid trunk. We have started the dissection from there, and we are slowly moving towards the internal carotid. Can you all see this internal carotid here? So as you flip the carotid body tumor around, we are now trying to, as I described in the in-text technique, able to dissect the internal carotid step by step. So in each one of these steps, it's very important for you to start here. So I started about 1 centimeter below the bifurcation of the carotid. Now this is a very important clue because that gives you what we call the white line of Gordon. The white line of Gordon is a very thin line that you get as a plane of dissection in the carotid body tumor. It's a very well described dissection plane that you will use. A lot of the times you'll have to use a mixture. If you see over here, the 3 important instruments that we use are, one is the scissors. Now it is important to use not a sharp tip scissor, but a blunt tip scissors here for sharp dissection of the plane to dissect the white line of Gordon. Number 2, we are using the Alice forceps. And number 3 is the vein loop for retracting the common carotid artery. These 3 are very, very important for us. You are seeing we use all the 3. The vein loop is being used over here. The Alice being used for counter traction. And part of the forceps and the suction we are using here to do some of our continued dissection. Now, this particular tumor was a type 2 tumor. It was not a type 3 tumor. And we had our cardiovascular surgeon in the backup. But the degree of engagement was close to 270 degrees, but we are confident that we will be able to dissect out the tumor effectively from the common carotid and the internal carotid without much of a trouble. So another very important thing in this entire bargain is, when you're retracting, you have to be very gentle and careful of the cranial nerves, especially the hypoglossal nerve, because that is going to come in your way, especially like a necklace over the carotid body tumor. And that's why it's very, very crucial for you to, that is why it is very crucial for you to understand and gently retract this region. Now, it may take more time in this kind of instances, but it is worthwhile for us to spend this time effectively without doing this. Sorry. So again, just explaining that point now, when you're describing this particular point, if you see this, this is the carotid body tumor, this is the internal carotid artery. We start the dissection from the common carotid artery and then go down to the internal carotid artery. And this is what you can do. The internal carotid artery being separated from the common carotid artery, and the white line of Gordon is seen over here. Now, it is not seen in this picture, but what you need to understand is the white line of Gordon is very nicely seen when you do this counter traction from the vein loop to your forceps. And now, another very interesting tip which was given to me by my cardiovascular surgeon, Dr. Ganesh Nayak, was, so I often used to use the scissors to do all the dissections using the blunt scissors. So we would use the vein loop to retract the common carotid artery and the internal carotid artery. I would hold a vascular forceps and I would start dissecting from 1 centimeter below the common carotid to get the white line of Gordon. Now, he also suggested that every time that you find it very difficult to use the scissor, using the periosteal elevator would be a very useful adjunct. And just keep this in mind that a periosteal elevator at sometimes to do some simple blunt dissection is a useful area. The other aspect, like I told you, very, very important step is to dissect it off the carotids with a very, very gentle area, with a very gentle dissection, either using a vascular forceps, counter traction, and blunt scissors, or with a periosteal elevator. There are two important shunts that have been known, which you can use. One is the Bard's Javid shunt and the other Bard's Brenner shunt. So the Javid shunt or the Brenner shunt are two carotid bypass shunts that have been well described. Now this is more of a T-shaped shunt, and this is a standard bypass shunt that is available. Now, most of the centers may not have this easily accessible. So please keep remembering it, that you need to importantly keep these two in mind if you want to create a bypass. Now, sometimes you may also want to, in cases when you feel that there's a very high chance of this, use a carotid stenting, an expandable carotid stenting, which can be done pre-operatively itself. So that can be done by your interventional radiologist. But if your cardiovascular surgeon is with you, you may want to keep the Javid or the Brenner shunt ready. In case you do not find it, your cardiovascular surgeon will be able to very nicely guide you that a suction catheter or a Ryle's tube also can be used in rare emergency instances. Now, intraoperative points. I'm going to close it soon. I think I have 7 more minutes left. So, intraoperative management points, predictive factors. There are a lot of predictive factors that can actually predict intraoperatively on the management plans, which is the arterial stump pressure. Now, it is well known that the distal stump pressure of more than 50 millimeters, it is known that there is a minimal neurological risk. So earlier in my slide, which I showed you on preoperative assessment of the carotid of the collateral circulation, stump pressure was one among them. So arterial stump pressure being more than 50 is a very, very reassuring step, and less than 25 is high risk. 25 to 50 is acceptable. So this is an intraoperative catheter that you put to check the carotid stump pressure. Intraoperative EEG monitoring could be another facility that people have been doing, where you actually check for the cerebral blood flow if it drops below the critical level of 18 ml for 100 milligram per minute. Now, what do you do when there is an inadvertent injury to the carotid? Because this is a reality that none of us can predict. Now, the most common reasons responsible for cardiovascular complications when you deal with the carotid are intravascular thrombosis with occlusion, unintentional ligation, transaction or laceration, or transient reduction in the perfusion pressure. These are some of the 3 reasons why we see vascular injuries that are common. Now, in these settings, what are the factors that you need to consider following injury of an internal carotid artery? And I'm going to tell you 6 important things that you need to keep in mind. Whether the recognition of the injury occurred intraoperatively or postoperatively is a very key determinant point. The earlier, the better. And it is better to have it done intraoperatively. Now, this generally happens, especially if you've had a very small cautery injury. Now, remember this when you're using a unipolar, and if you've had a very tiny cautery injury or a very small other injury, or you have denatured the adventitia, you need to be prepared to say that post-operatively this patient may have a blowout or may have a vascular insult. Now, the presence of severity of neurological deficits, the time from injury to its recognition is very crucial. A quantitative assessment of collateral circulation, like I described earlier, the history of wound contaminations or radiations, and overall prognosis. Now, what do you do if the carotid is injured? It has been ligated, and restoration of flow. So these are 2 important things that I will just highlight here. Now, the first thing, what you do if you have injured the carotid and there's nothing much you can do to repair it, you ligate it. Then the second step is restoration of flow. Now, the restoration of flow, there are 2 simple, important, quick steps. One is the table position and starting 100% oxygen so that it facilitates the opening of the circle of vessel. So there are a couple of points here. One is immediate detection of accidental ligation and removal of those ligations and repairing quickly with an 8-0 or a 9-0 vessel. Intravascular thrombosis can be, if recognized, you can look at in later settings, arterectomy, thrombolectomy, which can be required, which is secondary to the ligations. Transaction of the carotid and repairing it with the graft or temporary shunting. These are all the important things that can be done in order to salvage the situation. It is also very pertinent to understand the location of injury, which means near the skull base, if it is less than 2 centimeters, then transfrontal craniotomy with vessel clipping may be required. I often turn to my neurosurgeon friends for this guidance, if at all we are in this particular area. Now, this is one single case that was managed by our interventional radiologist. This particular case, I'm sorry, the video is not playing here, but this particular case was actually managed. A carotid body, the carotid blowout case was actually managed by our interventional radiologist without the surgeons intervening. They quickly were able to, within a span of half an hour, shifting this patient from the ICU into the interventional radiology team and putting a carotid stent to prevent the bleed. So these kind of things, this was not in a carotid body tumor, this was in a malignancy case, but I'm just kind of reiterating the fact that a multidisciplinary role of an interventional radiologist, a radiologist, a surgeon, a cardiovascular surgeon is very pertinent in this particular surgery. So I'm just, these are some of the 2-3 slides I'm just showing you that they had, they did the carotid stenting that you're able to see in this area. And following the stenting, the entire stent was dilated with a balloon. And after that, the complete bleeding was stopped. So I'll leave you all with these thoughts now at this. And I think if you have any questions, you can bounce it across to me. Thank you.
Thank you, sir. Thank you for the great presentation. I apologize for some of the listeners who are having some trouble with the video. So that's the reason I shared on the Facebook. And anyways, I'll make sure that the video is available later on this webinar. So as of now, there are only just a couple of questions for you, sir, in the chat box. So one of the question is by Dr. Amer Ahmad. How we differentiate between thyroid scan picture and a gallium scan?
How do you differentiate between thyroid scan and a gallium scan?
Yes, sir.
So I think the most important thing is the difference is here you are not using a gamma camera. More importantly, what you're using is more like a PET scan. So the difference here is going to be like more like an iodine scan versus a PET scan. And that's the simple differentiation you should know. The gallium proton scan is more like a PET scan, whereas the scans, the thyroid scans are the simple gamma camera related iodine scans.
Okay, sir. Our next question is by Dr. Achit. Is gallium-68.NX scan is necessary preoperatively for all the cases?
Definitely not necessary, but I would like to reiterate, I nowadays in my counseling add this. The reason I'm saying this is nowadays we are in a very interesting era of medical legal litigations. So we don't know who among them is prepared, who is not, but the data shows us that 10 to 20% can be multicentric and up to 40% to 80% either familial can be multicentric. Now with this in mind, it is better to counsel them that particular setting can be possible, which means the option is with them rather than forcing, because I've seen 2 multicentric cases who came to me later on asking me years later that I had got this particular procedure done years later. Why was this particular thing not told to me? Maybe I would have arranged the money, I would have arranged it, but this was not even discussed with. So it's very important for all of us to understand it is better to nowadays talk. Don't try to convince them, but at least speak to them about the science of it. If you have it available with you, tell that it's available. If you don't have it with you, tell it's not available with you, and leave the option to them to say that if you want to consider it, you can consider it, but it is not mandatory as of now.
Thank you, sir. So our next question is by Dr. Abhimanyu. What adjuvant treatment to give for malignant paraganglioma with nodal metastasis?
So as a general thing, the one simple thing that we can give in this kind of settings is adjuvant RT. Now again, in these settings, what I would want to reiterate is most of the time surgery is the first answer. So clearing them off completely, because these are radio resistant tumors. So a clear answer, if it's a rare instance that you found a metastasis, better to do surgery. Following surgery, you may have to give adjuvant RT. Chemo is not sensitive in this group.
Thank you, sir. So our next question is by Dr. Rahul Singh. What about doing a DOTA tech scan?
DOTA tech?
Yeah. I think...
no, I didn't quite get the question.
Okay, sir. Dr. Rahul Singh, kindly repeat your question in the chat box. So, sir, as of now, those are only the questions which are in the chat box. The new question has come up. What is your What is your take on role of observation in young patients? From Dr. Archit.
Yeah, so again, most of these people who are young will eventually become symptomatic. eventually will become symptomatic, because like I told you in the slide, the tumor doubling time of this particular tumor is 7 years. So if you calculate that, and if this person is at 30 and if he's going to live up to 70, you can imagine the size of the tumor that is going to be there.
Okay, sir. Sir, next question is, sir, have you come across IC injury during a surgery by Deepthi Patil?
Once I have.
So next question by Dr. Abhimanyu. Cranial nerve passing
And
through the tumor.
I'm just wanting to tell you, sorry, no, go on.
Yes, please continue. You please continue.
No, you continue. Go on.
Next question by Dr. Abhimanyu. Cranial nerve passing through the tumor, will you preserve them or sacrifice?
No, you should never sacrifice them, because remember, these tumors are very, very forgiving. They are never involving these nerves. They just simply stretch the nerves. So gently dissect them, take an hour extra, spend time there dissecting that area, and you'll be able to save most of these branches. Never look at sacrificing.
Okay, sir. Next question by Dr. Prabhat. If type 1 or type 2 tumors reaching up to the base of skull, how do you take care of distal ICA control?
So again, the trick I'm telling you is the ICA 2 centimeters are required. But remember, this is not squamous cell carcinoma. It will never be infiltrated. So you will be able to follow the white line of Gordon. The trick is to start at the common carotid artery 1 centimeter below with the white line of Gordon. Slowly keep dissecting it upwards. As you go upwards, you will be able to realize that when it reaches that particular place, you will be able to, with simple finger manipulation, as I was showing in the video, will be able to dissect out majority of them.
Okay, sir. So as of now, that's the end of the questions in the chat box, sir. So I request all of the members to find the link for the master classes of nature in the chat box. So you can contact Dr. Vishal. I'll put the Dr. Vishal's contact number and email address also inside the.
I'll send you the link, Bhargav. You can ask them to reach out to Ankita.
Okay,
She
sir.
will be able to guide each one of them with the memberships and all that. I would want each one of them to take benefit of this.
Absolutely, sir. I'll upload them for their reference, for future reference in Facebook also for them, so that they can get to in contact with me or you anytime soon.
Sure.
And so there's just one last question by Dr. Abhimanyu has just come in. That when do you plan for mandibulotomy in large tumors?
I think, see, this is a very relevant question. Typically, you do a mandibulotomy if you cannot get distal access to the carotid. Now, if you ask me, I have never needed it till date. I've never needed it till date, but it's a very important thing to keep that as a backup plan. That if you can't get a distal 2 centimeter of the carotid, the only two options for you is to drill that area or to do a mandibulotomy to get better access. So not to hesitate to do a lateral paramedian or a lateral mandibulotomy to gain access to the carotid artery very meticulously in that region, so that you are able to get a better visualization of the distal stuff.
Okay, sure. Thank you, sir. So, so that's the end of the questions in my chat box. So, thank you for the great presentation, sir. And looking forward to one more presentation from you. And I'll put all the links for our nature masterclass and everyone now in this chat box and leave it open for a couple of minutes.
Thank you so much. Good day.
Thank you, sir. Good day, sir.